is the director of the Africa CDC. As usual, he'll be taking us through the situation of COVID-19 on our continent and then taking your questions at the end of it all. But for you to be able to ask your questions, please use the following WhatsApp number, +251 9455 2310, +251 945 502 310. You may also want to use the live platform or the question and answer session when we get to that. Now we are coming through to you on the African Union channels, and those include Facebook, YouTube, and the live stream. From the Africa CDC side, you can also join us on Facebook and on YouTube. And we are coming to you in English and French for the moment. Now, this is a press briefing, so we really welcome questions from members of the media. If we have any other people who are listening in to our briefing, please kindly let the media ask their questions first. All right, so now it's time for me to hand you over to Dr. John Nkengasong, the director of the Africa CDC, for his briefing. Dr. John, good morning, and you have the floor.
Good morning, Wayne, and greetings to all of our colleagues who are online from Addis Ababa. Let me first of all start by acknowledging the sacrifices, the tremendous sacrifices that our frontline workers continue to invest in this struggle against the COVID-19 response across the continent. And of course, appreciate the tremendous contribution that the media have been working with us since the start of this pandemic to transmit the accurate information and, of course, mobilize the community. As we do every week, we will do an update on the epidemiological situation and then focus on some of the things that Africa CDC is doing, and then conclude with an update on the vaccine situation. So first of all, the epidemiological update. As of AM East African time today, the world has recorded over 106 million cases of COVID-19 infections and more than 2.3 million deaths, resulting in a case fatality rate of 2.2%. In Africa, amongst all 55 member states, we've recorded 3.7 million cases of COVID-19, representing about 3.5% of total cases reported globally. Of that number, 3.2 million have recovered, and this represents a recovery rate of 88%. Unfortunately, 96,000 individuals have died, that is of the 3.7 million, and this represents a case fatality rate of 2.6%, which is again still about 0.4 points higher than the global average. 5 member states have reported the presence of the 501Y V1 variant. And this is the variant that was initially reported in the UK. And these 5 countries include Ghana, Morocco, Gambia, Nigeria, and Senegal. 7 member states have also reported the 501Y V2 variant. This is what is commonly known as, this is the variant that was initially identified and reported in South Africa. And the 7 countries include Botswana, Comoros, Ghana, Kenya, Mozambique, South Africa, and Zambia. 5 countries that are accounting for more than close to 70% of the cases are South Africa with about 40%, Morocco 13%, Tunisia 6%, Egypt 5%, and Ethiopia 4%. In terms of the case fatality rate, over the last week, there were 2 additional countries that were added to the list of last week for a total of 20 countries or 36% of the countries that are now reporting a case fatality rate of over 2.2%. The 2.2%, again, is a benchmark of where the global average is. So in terms of the changes, if you look at the epidemiological week 5, that is the week between 1st to the 7th of February this year, the continent recorded 99,710 new cases and 4,102 new deaths were reported. So in terms of the new cases, it represents 25% decrease in cases. And in terms of that number represents 28% decrease in deaths over the previous week. So that is very good news, very encouraging news. And we all wish that that trend continues. The highest proportion of new cases reported for this week were from Southern Africa, 45%, followed by North Africa, 23%, West Africa, 19%, East Africa, 9%, and Central Africa, 3%. 5 countries that reported the highest number of new cases include South Africa with 22,000 cases, Nigeria, 8,500 cases, Zambia, 8,500 cases, Tunisia, 7,700 cases, and Mozambique, about 6,000 cases. So if we now look at the last 4 weeks and ask ourselves the question, what changes have occurred, then we see the following trend. That is between January 11 and February 7. Overall, there has been an 18% average decrease. Remember, this is average decrease the last 4 weeks in new cases in Africa. And if you look at the different regions, they include 13% decrease in North Africa, 26% decrease in Southern Africa, where a lot of drastic decrease is happening there. But a 14% increase in Central Africa, 22% increase in East Africa, and a 5% in Western Africa. So if you sum all of this, you have an average decrease of 18%. So if we now look at over the last 4 epidemiological weeks, we notice the following trends in the most populous countries in Africa. We observed that South Africa has recorded a 35% decrease in new cases, Egypt 17% average decrease, DRC a 6% average decrease, Kenya 5% average decrease, and Nigeria an average of 0.2% decrease. In terms of new deaths, deaths over the last 4 weeks, we noticed that South Africa has reported or is reporting 11% average decrease, Kenya 6% average decrease, Egypt 4% average decrease, Nigeria 31% average increase, and DRC 5% average increase. In terms of testing, as a continent, we are recording cumulatively 32 million cases tests conducted since this pandemic started. Let me now segue to the vaccines, and with a focus on the AstraZeneca vaccine and the story that we've all read this week in South Africa. And I will just walk you through what we know and then what our recommendations are. So on February 7, 2021, the South African government announced a temporary hold to the rollout of the AstraZeneca vaccine, which was manufactured by the Serum Institute in India, following reports that the vaccine only offered minimal protection against mild and moderate cases of COVID-19 infections. This was based on a placebo-controlled phase 1 and 2 trial conducted by the team at the University of Witwatersrand, South Africa, conducted in collaboration with the Oxford University. The study recruited 2,000 relatively healthy and young volunteers with a median age of 31 years with very few comorbidities. The aim of the trial was to assess the safety, immunogenicity, and efficacy of the AstraZeneca vaccine for the prevention of COVID-19 caused by the predominantly circulating new SARS-CoV-2 variant, that is the N501V.V2, or commonly called the B1351. The vaccine disease symptom COVID-19 was 21.9. This efficacy was below the minimum efficacy threshold of 50% recommended by the emergency use of vaccine candidates. Viral neutralization induced by sera from vaccine against the new variant was reduced when compared to the previous variant of the coronavirus. Protection against moderate to severe disease, hospitalization, and deaths could not be assessed in this study as the target population were at low risk. Again, the median age in this group, the study group, was 31 years. On February 9, 2021, the Africa Centers for Disease Control and Prevention convened a special session of the African Task Force for COVID-19 to review existing data and evidence and make the following recommendations. One, that for countries that have not reported the circulation of the SARS-CoV-2 variant, that is the N501Y.V2 variant, we recommend that they proceed with the rollout of the AstraZeneca vaccine. And if you all recall, the initial studies that were done reported an efficacy of about 66% of this vaccine, which is above the 50% threshold. Second recommendation from Africa CDC, for countries that have reported the circulation of the SARS-CoV-2 variant, we recommend the acceleration of their preparedness to introduce all vaccines that have received emergency use authorization or approval by the regulatory authorities. Consideration should be given to the effectiveness of the vaccine against the variant, that is the N501V2 variant, or any other circulating SARS-CoV-2 variants in the country. All countries are then expected to expand their capacity or capabilities to conduct a genomic sequencing surveillance. And Africa CDC can support this effort. We have, through our Africa CDC Pathogen Genomic Initiative, we can and are in the process of supporting countries to generate more genomic sequencing in the context of surveillance. Our target is to generate about 50,000 genomic sequencing in the next coming months, so that we better understand the lay of the land with respect to the new variant. And lastly, that all countries should continue to generate data on the safety and efficacy of vaccine candidates in populations that are suspected to have this variant, so that we generate very quickly data that will inform us on the rollout. So let me end by just giving you a very quick update on the Ebola situation in DRC, which I will call the 12th Ebola virus disease outbreak in the Democratic Republic of Congo. The government of DRC reported on 7 February and the 12th outbreak of the Ebola virus disease in Butembo area in North Kivu province. Since then, more than 70 contacts have been registered and are being followed. So these are not cases, but contacts that are being traced. The government of DRC, through the Ministry of Health, is working with partners, including Africa CDC, to establish coordination and response mechanism that will help contain the outbreak as quickly as possible. So as you can see, this is very early, and we have a team in country the Africa CDC in-country staff that will be supporting the government to look into this 12 outbreak. So thank you, Wayne. Let me return the microphone to you.
Thank you very much for that briefing, John. And we move straight into our questions. The first one is coming from Coletta Wanjohi with FSN. And Coletta says, following South Africa's decision to switch from AstraZeneca to Johnson & Johnson, does this cast a shadow on the usage of the vaccine in other parts of the continent, given that the recent COVAX allocations show that some countries are ready to receive AstraZeneca? So that's one question. She had a second one. Could you kindly speak to the just concluded African Union Summit's discussion on the idea of patents for COVID vaccines? So those are two questions from Coletta.
Yeah, sure. I think they're all very good questions, Coletta, as always. So our recommendation for the use of the AstraZeneca vaccine is very clear. I mean that if you have evidence that the variant is the 501 V2 variant is dominant, the keyword here is predominant in the country, then we recommend that that it should not be deployed for the obvious reasons that we have, as we indicated, it will have reduced activities in neutralizing antibodies as such. But for countries that have not identified this variant, there's absolutely no reason why it should not be used there. I think, again, remember that the threshold for any vaccine to be used is 50%. So I think we should encourage countries actually to use that vaccine where they do not have evidence of that variant. Having reported 1 or 2 cases in a country doesn't mean that the variant has dominated. We'll only be cautious in areas that have an extensive takeover of the pandemic by this variant. I think that is very clear. And we will today publish our guidance. I mean, all what I just explained to you will be put online so that you can extract as much as possible from that and we circulate it. And we count on all of your efforts to share that information with countries so that they should see what our position is. And I believe WHO just published similar guidelines yesterday. With respect to the AU summit that just ended, on patent issue, I think the EU is rallying itself around the call for transfer of technology, the so-called TRIP, so that it can enable the continental manufacturing or transfer of technology. We know that we will be in this race for vaccine for long. And for several reasons, we truly are dealing with a new virus. We don't know that for how long, when people receive vaccines, the protection will last. And if it happens, it so happens, and just so happens, this is hypothetical, that the vaccines will require that we do periodic vaccinations. You also require that Africa is well positioned and equipped to be able to manufacture vaccines locally, so that, or continent-wide, so that we can at least meet a demand. I mean, for a continent of 1.2 billion people. So it was a very much welcome move for the continent to apply its political the weight behind the need for the transfer of technology through the WTO.
Thank you for that. Let's move online, and we have Esther Nakazi, who is on standby to ask a question. Esther, good morning. Please introduce yourself, your organization, and then ask your question.
Good morning. Thank you very much for this opportunity. And my question is about, one, Dr. John, how many countries have capacity to do genomic sequencing in Africa? Secondly, do we have Ebola in Tanzania? Because there is a rumor of a strange disease, but we do not know whether it is Ebola or not. And then lastly, what happens to the countries that do not know whether they have the South African variant? What recommendations does the Africa CDC have for them? Thank you very much.
So Esther, these are very excellent questions. In terms of countries that have the capacity, I am tempted to name some, but in naming countries, you run the risk of omitting some of them. But so take it that what I'm going to say is not an extensive list of countries there, but at least for those that we are working closely with Africa CDC, we include South Africa, Kenya, Ethiopia, Morocco, Tunisia, Uganda, South Africa, DRC, Gabon, Nigeria, of course, Ghana, Senegal, and again, I run the risk of missing others there. So I think there is a growing capacity across the continent that we, Africa CDC, have supported to establish or to strengthen over the last 1 year in the area